when you have a patient coming into a hospital who's very ill, maybe dying if we don't treat them, our assumption is that treating and attempting to prolong life is the right thing to do. And that indeed, from an ethical, professional perspective, is the right thing to do. But is it what the patient would want? And not knowing that answer, what the patient would want, is extremely distressing, not just to the health professionals who are caring for the patient, but also for the family. The family is wondering, are we doing the right thing? And so I started to witness these repeated cases, and then a few years later, I started to do consults, ethics consults. I would be asked to come and talk with a family or a patient about a medical decision, but the complexity here was not the medical scientific part, it was the ethical part. Everyone wants to live as long as they possibly can, but what I find is that Americans also very frequently, well over 90% of the time, say, I don't want to die hooked up to machines. I don't want to suffer unnecessarily. I don't want to be put through things that aren't going to help me. I mean, I don't want to say, this is common sense, right? I mean, I don't want medical care and the risk and the suffering that can come with that medical care when I'm very sick if it doesn't really translate into anything good for me. I mean, so Americans are at least that self-interested that yes, they want medical treatment that's going to help them. And they often don't care what it costs. If it truly will help them, they want it and they'll pay for it. Or someone else will perhaps. On the other hand, they also don't want to go through things that create suffering for them and don't help them. They don't want to die hooked up to machines. This isn't a medical problem, is it? It involves medicine and it involves medical care, but this is a human problem. One of the things that has really impressed me in some of the work I've been doing is that this problem faces everyone in the world who has access to advanced medical technology. I've been to Australia, Singapore, Hong Kong, Germany, England, Spain. In all of these countries, no matter what their health system looks like, if the people have access to advanced medical technology, this question about, well, how much should I get? What should I get, particularly at the end of life, faces everyone in the world. And it's the real human problem here of what's important and what can medical treatment do for me as an individual, live my life, and when does it interfere with kind of human life? When does it go beyond what will help me? And this is the struggle, and the problem comes in every country, here in the United States as well. If we don't talk to the patient and we just let things drift along, and now we have a medical crisis, and underlying that medical crisis is someone who's already extremely sick, what should we do? And there's no way of answering the question, no matter where you are. There's no way of answering the question for the family, for the doctors, and are we doing the right thing? It's a huge moral problem, and the only way that I can see of actually resolving this moral problem so we give each patient the treatment that will benefit them from their own perspective is by talking with them in advance. Some people who attend churches who are kind of, their faith is extremely important to them, they want to know what does my church teach about this? What are the moral, theological teachings about my life and how my life and my medical decisions fit together in terms of my faith? So I see this as a very understandable and natural kind of connection between individual choices and the fact that individuals aren't just coming into their doctor without connections and faith and traditions behind them. So really, to make these decisions, you have to be informed not just about the treatment options that you have, but also who are you, where are you in your family, and how does the your faith inform what's important about life. We reached out to our Catholic bishop and our Lutheran bishop, and we said, here's what we're doing. This is why we're doing it, and we would like your support. Those bishops, with our encouragement, wrote a letter to their priests and ministers saying, we support this project, and we encourage you or someone from your church to go to the training that's being provided so that you can participate in this planning process within your churches. So we have trained ministers, we have trained parish nurses, we've trained lay ministers with the goal that they would provide a planning service within their congregation for patients particularly who may have an illness that's getting worse over time. One of the amazing things that I've discovered is that many of these pastors actually request a copy of the advanced care plan, which they keep in their file. And so when that member of their congregation gets sick and goes to the hospital, and they know that big decisions need to be made, they actually pull that plan out and look at it and review it before they go to the hospital. And now they can play a more, I think, involved role with the family and the patient. So if the patient's lost their capacity, they can say to maybe the son from out of town, you know, your mom thought about these issues, and I have a copy of her advanced care plan, and I've looked at that before I've come here. And here's what she expressed in that. And here's what I understand she meant, because we talked about this perhaps as part of her faith and the part of her religious belief. And many of our ministers are saying that they now can play a much more involved and important role in helping members of their congregation, not just make a plan, but then to have that plan carry out in those very crucial and important decisions, so that that decision is not only in keeping with the individual's preferences, but in keeping with the faith tradition that they live in. What Americans need to understand is that we're not asking them to give up anything. We're asking them to be more in control of their treatment. They can develop more individualized plans, which will probably be more beneficial to them, allowing them to live in the places, their home, that they would choose to live. And we use fewer resources doing this. We learned early in our work at Gundersen that doctors simply do not have enough time to sit down and have these in-depth conversations with patients about future medical care. So we decided to create a new role called Advanced Care Planning Facilitators. So we train chaplains, nurses, social workers, depending on the setting they work, and we train them to have very competent and skilled conversations with patients, working in conjunction with the physician or the nurse practitioner or the physician assistant. So the provider, if you will, the health professional, is still in touch and still in contact and still part of the planning process. But these facilitators spend the most time with the patient, having the conversation and with their family, so the patient has the time they actually need to go through this planning process, so we really end up with informed decisions which the family understands and supports. I think we live in a world in which we have to share resources. That's a spiritual value for me. So if I receive medical care and it reaches a certain stage and it's not going to change the outcome for me, but a lot more money could be spent, I would say, you know, I've used enough of the resources of our community and of our world to try to keep me alive. A good effort was been made at this point. And now the cost of this care has reached a point that I no longer feel is ethical. Because other people don't even have basic needs being met. So that's a personal value that I hold. I'm not saying everyone should hold it. I'm not evangelicalizing. I'm not trying to promote it. I'm just saying that that's an example. Other people have told me I've reached an age and I know I believe in heaven, and I'm ready to meet my Maker. And even if you could do something that prolonged my life, it's not important to me anymore. I'm ready to move to what is a more important life to me with my God. So that might be another kind of religious value I've seen patients express. One of the questions that I'm often asked is the question about, well, why is this so hard to discuss? And the common answer is people don't like talking about death. It's a taboo in our society. And I get that answer. It makes some sense on the surface. You know, we probably don't like to think about a time in which we don't exist. But I don't think it goes to the heart of the matter. I don't think it really answers the question of why this is so hard to discuss. And I think there are two additional reasons, and maybe they're the main reasons in my opinion. The first reason I think is quite straightforward, which is we don't know what to say. So if you've ever been in a social situation which you're kind of out of your element, you're in a different social group and you don't know how to talk about the things they're talking about, the tendency for any of us is just to be quiet and listen. And I think most of us feel that way when it comes to these issues. What would I want in the future regarding my medical care? I don't know. I don't even know how to talk about that. I don't even know what the questions are, much less the content of the answers. And so I think one of the reasons we don't talk about this is because we have no idea. And we don't have any idea because we're the first human beings in history to actually be asked this question. Even our parents almost never had to ask this question or be faced with this issue. So it's a new problem. And as a new problem, we feel a bit intimidated, a bit lost, a bit uncertain about what to say, and so we're a little bit out of our element, and so we keep quiet. One of the goals of our program in La Crosse is not just to help patients talk about this, but to help them talk about it with their families. And what I can see already is that we have really transformed our community in lots of ways. It's now more comfortable for people to talk about this, and they're starting to understand the terrain a little bit. They're starting to understand what they need to talk about, and it's becoming part of family culture, which is exactly where it should be. When you talk about these issues, there is no way for you to be superficial. This is a very intimate conversation. And I believe that one of the other barriers, so we're not familiar with the terrain and what to say, so being uncertain kind of lets us not talk about it. But the other thing I think that's a real barrier is that when you talk about these issues, you're really talking, if you will, about the meaning of life, about your religious beliefs and faith, and ultimately about who you are. I think this conversation is probably as intimate as talking about your own sexuality. And that's a little frightening to most of us. And it's a little bit unsettling, and to tell your family what's most important to you at this point in your life when you're critically ill, maybe they'll reject your ideas. Maybe they'll laugh at you. Maybe they'll discourage you from believing what you believe. That could be painful or embarrassing or humbling. And so I think the second reason we don't talk about these is we're afraid to be intimate. It's a little scary for us. And this is one of the reasons I think our facilitators are so important, because what our facilitators can create is a safe and sometimes what I would call a sacred space for families to have this conversation. And it's very typical when at least a facilitator is particularly successful at creating that space for a family, for the facilitator to fade out of the conversation. They don't leave the room, they just find the families now talking with each other. And what they will report to me is that what they experienced was a sacred space.